Hi everyone, I'm Tony Rivera. I'm the Digital Marketing Coordinator here at the Christopher Dana Reeve Foundation. I'd like to welcome you to this month's online chat with Nurse Linda. Nurse Linda has been a leader and provider of rehabilitation nursing for over 30 years and a friend of the Christopher Dana Reeve Foundation for close to 20. As a moderator Ask a Nurse discussion, she focuses on contributing functional advice, providing the how-to on integrating various healthcare improvements into daily life and answering your questions. Nurse Linda, welcome, and take it over.
Thanks so much, Tony, and hello, everyone. I'm so happy you're able to join us for this afternoon's webinar. There's been a variety of topics discussed on the blog, and as always, I'll be answering your questions as we go along. I did want to open up the meeting today with just a little bit of information about autonomic dysreflexia, or what is commonly just referred to as AD. Autonomic dysreflexia is two words, but they're two big words. They're kind of hard to get them to come out of your mouth. So AD is a lot easier. This is a problem that develops sometimes with people who have spinal cord injury. Why some people get it, we have no idea, and why other people don't get it, we have no idea. So you may or may not have experienced this. It's generally a problem or an issue, a concern that people have who have an injury level at T6 or higher. However, there have been many documented cases of individuals who've experienced symptoms of autonomic dysreflexia, even with injuries much lower in the spinal cord, sometimes down to even T10. The reason for this is that even though our bodies are all very, very similar, we're constructed in the same way. We have two arms, two legs, two eyes, a head on top of our body. We're all pretty similar, and yet the intricacies of our human body are much different. And so some people will have issues with AD who have their injury at T6 or somewhere above T6. And then sometimes, because the spinal cord's just not exactly the same in every single person, somebody might have the symptoms of AD in a lower part of their spinal cord, even with injuries from T10 and above. So almost at the end of the thoracic spinal cord, you can notice these, although it's more prominent in those with injuries above T6. And sometimes people will have an injury at one level, but maybe one side, the injury on the spine within the spinal cord might be lower on one side, so it might not be perfectly straight across, or the injury might be not perfectly round. Or there are all kinds of little intricacies that are different about different people who can still have this. So it's not that it's pretty uncommon in people with lower level injuries, but it's not impossible. And so it's important for us all to note. Now, if you've never had an experience with AD, good for you. It doesn't mean that you can't develop it later on in life. Sometimes through the aging process, or sometimes through advances of advancing spinal cord injury, especially if you have spinal cord injury from a disease process. The disease might not be quite so involved early on, but as that progresses along, you could end up with symptoms of autonomic dysreflexia, or there are just a variety of things that can happen to people as we get older, and our bodies tend to have more trouble adjusting to chronic conditions as we get older. And so people might develop it later on. So sometimes people think, well, I didn't have this when I was in the hospital or in rehabilitation, so I don't need to worry about this anymore. But in fact, it is something that can be lurking out there for great long periods of time. So what exactly is it? It's a problem with the autonomic part of the nervous system, or the part that I like to call that happens automatically. So what happens in the body is that the body detects something is wrong below the level of the spinal cord injury. Now, if you have sensation, you would notice that there's something wrong, and you would tend to adjust your body, or you would attempt to correct the problem. But when that message from the part of your body below the spinal cord injury is not being transmitted directly up to the brain because that spinal cord injury is blocking it, the nerves and the muscles below the spinal cord injury are still working. They detect something is wrong and they're sending that message. The message just is not being received by the brain because of the blockage of the injury. So what happens is the body is going to try to get that message to the brain in some particular fashion. And that is always the challenge, is that the body will attempt to circumvent or go around the spinal cord injury. And so these triggers occur within your body, and your body will still respond. But since the message is not being appropriately sent to the brain can't read what the message is. It just sends out all of its defenses to the area below your level of your spinal cord injury. So what happens is if you get, like you're sitting on your chair and you're getting uncomfortable seated in your chair, maybe your pants are doubled over or you're in bed and the sheets are crumpled up underneath you. Well, if you had a nervous system that was completely sending those messages back and forth efficiently, you would roll over, you would move whatever linen is underneath you and get that out of the way so that you would be seated or lying more comfortably. But since that can't happen, the body just sends out full defenses and says there's something wrong. So it doesn't know if it's a little something wrong or a big something wrong, so it just sends full defenses out. And what will happen is that your blood pressure will rise. So you have to know what your normal blood pressure is, because your blood pressure will start to go up. Now, if you would have your blood pressure taken, and it would go up to say 120/80, and somebody would read that, they would say, well, that's a normal blood pressure, so nothing's wrong. But after a spinal cord injury, your blood pressure has a natural lowering to it, so you get low blood pressure. So you have to know what your average blood pressure is. It's never going to be exactly the same 2 different times, but it's going to be in the same ballpark. So if you have a lower blood pressure of, say, 90/58, that might be average for you. So having this rise of 20 to 40 milligrams of mercury, or each number is a milligram of mercury in your blood pressure. So having it rise between 20 and 40 milligrams might be a huge increase in your blood pressure, but it will look normal compared to the regular population. So you need to know what your blood pressure is. Now, people don't generally feel their blood pressure going up, but they might have side effects of the blood pressure going up. And one of those key side effects is to get a really strong pounding headache. So most people will notice that they have autonomic dysreflexia, or they're having an episode of it by this pounding headache, but not always does it come in the form of just a pounding headache. So there are other symptoms that you might notice that aren't quite as dramatic as that. So you might have just an uneasy or a queasy feeling. Sometimes people will describe it as, I just feel impending doom. It's kind of hard to describe unless you've had this sensation. So it's this real apprehensive, kind of nervous, queasy sort of feeling that just something bad is happening, but you can't put your finger quite on it. Some people might have changes in their vision. They might have some blurry vision that comes up. It's just not quite as clear. Sometimes people have nasal congestion, so just all of a sudden they get a stuffy nose. And sometimes people will, if that's their only symptom of AD, they might say, oh, I might be getting a little cold, I have an allergy. Some of these symptoms are kind of easy to be swept away when they're not really dramatic, like the pounding headache. Sometimes people will sweat above the level of their injury. Their skin might be flush. They might get goosebumps, or they might just feel tingly. Sometimes below the level of your injury, you might get nauseous. You might feel like you're going to vomit. You might have chills, but no fever. Sometimes your skin can become clammy, so it can be sweating up above the level of injury and very cold and clammy below the level of injury. And you might also get very pale. You might get really red in the face with a pounding headache, and then the rest of your body might be very pale. So some people will have one or two of these symptoms of autonomic dysreflexia, and other people will not have such dramatic. Some people will have the full presentation. They'll have every single symptom. It becomes very easy to identify you are having a symptom of symptoms of autonomic dysreflexia. And then other people might have such slight feelings of any of these symptoms, maybe only one, maybe two. And as I said, it's real easy to kind of excuse them away and not even think about them because they're just so subtle and it resolves, and so you don't really think too much about it. But it's important to know because when your blood pressure raises like this, that can be really difficult on the body, and it can lead to other problems with even having rupture, sometimes very rarely, but sometimes left uncontrolled, people can even die from this. So it is a medical emergency. It is something that you want to monitor and watch for. Even if your symptoms are very slight, you still want to monitor for that because these sharp increases in your blood pressure can be really hard on the arteries and hard on the internal body if it's consistently going on over and over again. Another thing that you might need to know is that some people don't have any symptoms of AD, but they still have it. And the only way it can be detected is if you're taking your blood pressure during some kind of process, like during your bowel program, and if you take your blood pressure and you suddenly have this rise in your blood pressure, then you would know, oh, I'm having autonomic dysreflexic episode, but I don't really have any symptoms of it, and you still need treatment because the long-term effects on your arteries and veins with this increased blood pressure can be detrimental over the long haul. So it can be silent, it can be very small, or it can be a very large episode. So a lot of times people think if they don't have that really critically large sudden onset with this headache that they don't have AD, but in fact they do. So it's something to be aware of. Now, the treatment for AD should be done very promptly, and it must be done quickly. And it's pretty simple. The very first treatment is to sit up suddenly. And what happens is it kind of takes advantage of two different issues that people have with spinal cord injuries. So they're having a spinal cord complication, they're having an episode of AD, they're getting the headache, they're feeling bad. If you suddenly sit up very sharply and sit up as tall as you can, so if you can get up to 90 degrees or pretty close to that, what will happen is that second complication of spinal cord injury will click in, and that is the sudden drop in blood pressure. So we know that when people get up, anybody with or without spinal cord injury, when people get up very suddenly and very sharply, their blood pressure will drop quickly. And what will happen is if you do not have a spinal cord injury, the vessels in your legs will constrict very tightly and very quickly, which will force the blood to pump back up into your head. It takes a little bit longer for a person with spinal cord injury to make that adjustment with their blood pressure. Their body will do it internally anyway, but it takes a little bit longer. So that sudden drop in your blood pressure when you sit up will bring the blood pressure down just as quickly as it popped up with the AD episode. There are also medications that you can take. Some people have episodes of AD that they need to take medications ongoing. And, just be prepared for it to happen at any point in the day. Some people only have rare episodes when we'll take medication only when needed. So sometimes people can be treated just with the sudden elevation of the head, and that will help resolve the blood pressure. no matter what, you still need to find out what caused that episode of AD. The number one culprit is a kink in the catheter or some kind of clogging, maybe a clot or a stone that's being passed that is keeping urine from draining out of your body. Sometimes people who drink a lot and have a big episode of diuresis, so they're putting out a lot of urine very quickly. Sometimes the bladder will fill so quickly that the urine will not be passed until they do their intermittent catheterization again. So if you take a lot of fluids very quickly, even after you've just catheterized, your bladder could fill up and you might need to catheterize again sooner rather than later. So that's the number one thing, is that the catheter might just be kinked. Maybe you need to do another intermittent catheterization. Maybe you have a urinary tract infection. So the number one thing that causes AD is some kind of problem with the urinary system. The number two problem is something that's complicating your bowel program. So if you become impacted, if you have hard stool, if you're doing a bowel program and that stimulation of the bowel program can sometimes trigger an episode of autonomic dysreflexia. And for those individuals, they are usually prescribed, instead of the regular lubricant used for the bowel program or even for the bladder program, you can get prescription anesthetic lubricant that will help decrease those stimulations while you're doing your bowel or bladder care. Other things that are known triggers are things like pressure ulcers, sitting with too tight of clothes on that are constricting your abdomen or in your groin, or even too tight around the knees. So people are really into these skinny jeans. And I can tell you this is not scientifically researched, but in my own practice, in my own world, since the advent of skinny jeans have come in, I see more autonomic dysreflexia because pants are so tight, just too tight, and the body's saying, hey, wait a minute, something's wrong here, something's constricting me. And so the way it delivers that message is through AD. So that's not very scientific, but I'll just tell you I see it. Something else that I see stimulating AD is people putting on their leg bag, and they put it on their leg. It's empty. It's nice and loose. It's first thing in the morning, and so there's no problem. But as the day wears on, if they're unable to empty the leg bag periodically, the weight of the urine in the leg bag pulls on the straps, the elastic straps on your legs, and that can stimulate an episode, or even the leg bag can be full so that no more urine can drain out of the bladder, and so that can stimulate an episode. So there's just all kinds of things. I have seen patients that are so have such a strong stimulus to AD that sometimes just if their skin on their legs are exposed while they're having a bath or a shower, and just a current of air blows across their legs and the hair on their legs gets stimulated, it can send off an episode of AD. A lot of people have AD episodes during sexual experiences. That's something to be aware of. I've had lately, it seems like, since so many people, again, are on one of these new phenomenons that are happening, and so many people are on computers that there's power surges behind your computer screens. They're happening all the time, but you don't really see them with your eyes. The computer screen just looks the way it looks. But what happens is there's little power surges behind that, and sometimes computer use and looking at the computer for too long can trigger an episode. It might not be a huge episode, but there might be just a little episode of stuffy nose when you use your computer, or having trouble with visual problems using your computer. Now, we're all supposed to, glance away periodically from our computer screens to give our eyes a rest. But if you're finding that you're having any of the symptoms of AD while you're using the computer, you might want to think about the computer use and it's not that you have to give it up, but you might need to move the computer to a different area of your home where there aren't quite such strong power surges, where away from other electronic equipment. You might need to wear sunglasses or a visor. Sometimes people who have their computer screen up in front of a window and then you've got the bright sunshine coming in and you're looking at your computer screen. So that's one of those things that people don't normally think about, especially if you're not having a full-blown dramatic AD episode. It's just this use of the computer. There are other people who have problems with autonomic function that do not have spinal cord injury. They have problems with autonomic function from other diseases, and so they're finding that more and more, the same type of things, but especially with computer use. That can include cell phone use. It can include watching television. So just be aware of those kinds of things and be aware of AD. If you do have an AD episode and you've not had one before, you probably will need to call for emergency help if you cannot get your blood pressure down by sitting up quickly. You will need to notify your doctor that you had these episodes, and be sure and write down and take notes when you had the episodes, what was going on, what happened, so that your health care professional can help you. There are wallet cards that are available through the Christopher and Dana Reeve Foundation. There's one on AD, there's one on sepsis, there's one on DVTs. Be sure and go to the Paralysis Resource Center button at the Christopher and Dana Reeve Foundation, Paralysis Foundation website, and you can download those pocket wallet cards. You can take them to your doctor, or if you have to go to the emergency room, you can take them with you. They're a card, they're about the size of a dollar bill, so they fit easily into your wallet, and they have information for you about these particular complications of spinal cord injury, what you need to do, and then there's also information that's evidence-based, so research articles are written on the cards, but there's information to your healthcare professional. So if you have to go to an emergency room, they're not familiar with you, maybe they're not that familiar with people with spinal cord injury, it's a good opportunity to say, oh, I got this card from the Paralysis Foundation. I think this is what I have, and then they can look at the card and see what the standard treatments are for these particular problems. It really helps a lot to get, kind of cut through some of the issues. So I do hope that you'll take advantage of that and the many other resources that are available on the Paralysis Foundation website. So let's go to some of these questions. And I see we have the regional champion program participant here in Missouri, so yay. It's always good. I'm here in Missouri too, so hello out there. Here's another person that's not been able to go to outside for 4 days as they've become so weak and in pain. Is there a hospital that can address this in myeloma ring? I'm not quite sure what's going on with this person, but they've become weak and are in pain. So it's definitely a good idea whenever you have any sudden change in your condition, for anybody with spinal cord injury without or any kind of chronic illness, or just anybody, if you've had a sudden change in your abilities, you need to see a healthcare professional so that they can work up your situation and see what's going on with you and what needs to be done. It might be something physiological going on, or it could be something maybe with medication that you're taking. There is something about myeloma, so if you have skin cancer, or if you've had any kind of healthcare problem at all, you really need to check with your healthcare provider so that they can make the diagnosis and give you the treatment that is particularly for your condition. There's another person here that writes in about syringomyelia, And so the doctors said that surgery can make matters worse, and so they can't imagine living like this. So let me just tell people about syringomyelia is a complication of spinal cord injury, and that is what has happened is when somebody has a spinal cord injury, no matter what caused the spinal cord injury, the way that the body reacts is that in the center of the spinal cord a little cyst forms once you've had a spinal cord injury. People who have disease might have several of these little cysts up and down their spinal cord depending on where the disease has affected their body and their spinal cord. So this little cyst exists, and it's a little hole right in the center. Even if you've had a bone fragment that's just pushed up against the side of the spinal cord, the result is always a little cyst in the center of the spinal cord. So what happens is that fills with debris and old blood cells. It kind of just collects clutter as the body tries to heal itself. We know that whenever the body gets hurt, white blood cells are sent to the area, and there are different cells that the body sends to try to repair itself. You can see this real easily if you have an injury on your skin. You can see the area becomes a little bit red and inflamed. That's all those blood cells trying to get there to heal and make sure that that area is healed up correctly. And then a little scar forms. So you can see that on your skin. But basically the same process happens if you have something that has injured the inside part of your body, especially as in the inside of your spinal cord. So people will have that little cyst, and that's the blockage that's keeping those messages from getting through. Now, that cyst will generally just stay the way that it is. However, sometimes the cyst, for whatever reason, again, these are kind of unknown medical mysteries, but for some sort of reason, the cyst sometimes tends to grow. It's usually several years after the spinal cord injury, but it can be quicker than that. So the cyst starts to grow and elongate, and the way that people will really notice this is when the cyst elongates downwards. You probably don't really notice it because you already have impaired function below the cyst, and so people don't really notice that their function has changed because it's already impaired. But people will notice when the cyst is elongating and enlarging towards the head. So when it's going up, because people will gradually lose some of their function, and they'll be like, whoa, wait a minute, something's wrong here. That's when you really start to notice these. You might not even notice any changes in your function or in the way that you do things with your body, but what might happen is it might be picked up on MRI scan. So the cysts, sometimes they'll do some periodic MRI scans and check that cyst to make sure it's not growing or changing or elongating in any way, and so it could be picked up. So what happens is when the syringomyelia gets enlarged, there is some surgery that they can do. It's a very risky type of surgery because that cyst is in the middle of the spinal cord. So to drain it, they have to put a needle in through the nerves of the spinal cord, because if you think of your spinal cord, it's like a really tightly wrapped ponytail. Only instead of being hair, so they're nerve fibers, but they're tightly wrapped, like being bundled up in a ponytail. And so to get to that cyst in the center, you have to drain it. You have to put a needle through the spinal cord and draw off that fluid. Now, this is the complications. When you put the needle through those nerves, there's going to be more damage because that needle is going to break through the nerves in this tightly wrapped, like ponytail-like structure. So that's one of the big worries. The other thing is that when you try to drain something in the spinal cord in surgery, Okay, if you can imagine this, you're on, in surgery, you're put to sleep. So everyone is on mechanical ventilation, and that machine is pumping air in and out of your lungs. So air is getting pumped in, then the air flows out, more air is pumped in, then it flows out. So that spinal cord is always going up and down as this air is being pumped in and out of your lungs. So it's very hard for a human to hold that needle and to hold it steady enough to get it where it needs to go. So actually right here in St. Louis, for my program champion here in St. Louis, there was a physician several years ago that invented a little device, and it has a clamp on each end of the little device, and they put these clamps on the vertebrae of the bony part of where that vertebrae are going down the spine. And then they'll cut out an opening of the vertebrae where the syrinx is. So they'll pull out that bone. They clamp this little device on either end of the vertebrae and attach the needle, and it has an automatic dispenser on the needle. So as they're removing fluid from that, the needle's going up and down exactly in motion with that person's body, because of these clamps are making it go in tandem with the person's body. So that has reduced a lot of complication with this process. You still have to have major spine surgery, which is huge. You already have a spinal cord injury, so going on mechanical ventilation is a problem. Laying on the operating table for hours can lead to pressure sores because you can't be turned during that time. So there's all kinds of physical issues with doing this particular surgery. Getting off the mechanical ventilation is much more difficult for people who've had spinal cord injury because of breathing problems. Even if you don't use mechanical ventilation even if you breathe regularly on your own, you still have muscular problems. Maybe your muscles aren't as strong in your abdomen, and you need your diaphragm and the muscles in between your ribs as well as your abdomen. So use all three of those muscle sets to breathe. So if one of those is less than desirable, it's difficult to get off the mechanical ventilation. So surgery is very dangerous, and doing this surgery where a needle's being put in there is also very dangerous. However, if the syrinx gets such that it becomes life-threatening, there are neurosurgeons who can and do these surgeries. They're just, you have to, anytime you look at any type of surgery, you have to look at the risk versus the benefits. And if the risks are so much greater than the benefits, then you don't want to do the surgery. So you have to get into that spot where the syringomyelia is such that, oh my gosh, yes, we really need to do the surgery. So those are what the downsides are, and that is why it's so difficult to find treatment, and it's a difficult problem to be in. Okay, now here's the little teeny tiny shred of good news. So at the Academy of Spinal Cord Injury Professionals conference, which was just held at the beginning of September, there was a group of researchers there that presented some findings about surgery that they had done on rats. This is not even thought about onto humans yet, but this was a one-time experiment that was done on rats. So it hasn't been repeated and validated by other scientists or other researchers. But what they did was they had some rats with spinal cord injury. They went in and did the surgery, and they drained that syrinx in the middle of the spinal cord. And before this, it was just kind of considered impossible. It was just too much damage to put that needle in there, and people wouldn't even think about doing this. Well, they did this on rats, and guess what? The rats got some return of function. this has just like turned everybody's head upside down, because it's like, no, we thought this was impossible. So now they've done it on rats, so they'll continue to experiment on that and with rats, and hopefully if it's successful, and that's a big if, then they'll move on to doing some different kinds of experimentation to see if that would help people to have those syringes drained more routinely instead of just in, more life-threatening sort of manners. So, this is something that is like really huge, and it was really exciting to hear about this at this meeting. But as I said, this is one experiment done in rats. We don't really know if it could be replicated. We don't really know if anybody else is doing this, but it has opened the door to a whole new line of inquiry. So we're going to be hearing more and more about this. And so this is something that I think is really good news, although it's, a pretty far off shot as to what's going to happen. So that's something to think about. So it can be difficult dealing with the syringomyelia. It can be quite a life adjustment because it's such a change from what you had before. But this is something that really needs to be, will be thought about, and you need to take full advantage of all your medical treatments that are available right now, and not just be, sitting around waiting to see what's going to happen to these rats later, but just to think about what you can do now with therapy and treatments to help get along and be able to adapt your daily lifestyle. It's quite an adaptation, as all the listeners with spinal cord injury can certainly attribute to. So keep a positive thought, because things are on their way, but do what you need to do right now in this moment in time as well. The next reader writes in that sometimes they feel that their upper body loses balance, and what can cause this? Well, it can certainly be caused from a lot of different things. So I don't know if you have a spinal cord injury or not, but sometimes not having that trunk support in which helps aid in your balance can certainly make you feel like you're losing balance, even if you're just tilted a little way. Sometimes people who have spinal cord injury at the higher level, even if they just move a little bit to adjust themselves, or they really need to hold on when they're doing their pressure releases so that they don't lose their balance. So it could be, if you have a spinal cord injury, that you feel like your body's losing balance because it is losing balance. When you have weak muscles in the trunk, it can be very difficult to support your balance. So sometimes tightening those trunk muscles and doing exercises to help increase your core strength will help if that's possible. So that would be, I think that probably the first place to start. And again, that's one of those things, if you feel like you are losing your balance and you didn't really lose it before, that would be something to talk to your healthcare professional about. When people have injuries somewhere in the trunk, say from like T4 down, well, I guess anywhere down their spinal cord, sometimes it's a lot more difficult to keep that balance, and it's a lot more difficult to tell where your body is in space, because you have this whole trunk that's moving as a unison, whereas your arms have different joints that move and your hands move, so you can see your body functioning different. But in that trunk, it's just one big chunk of body there. There's no individual joints in there, so sometimes people don't really see how their body's functioning in the trunk as you can with your arms. And so that would be a good place to start, is looking at your core, but talking to your healthcare professional and saying that you notice something different, and then they can set you on the right path for getting that core therapy for your trunk. Okay, so here's a person that writes in, and this is an excellent question and one that I would love to talk about all day long. So as a professional nurse concerning SCIs, do you think it's possible for doctors to find a cure for these dreadful injuries, maybe sometimes down the road? Okay, Danny, I will respond to your question with this is my own personal opinion, but it's from a person who has worked with people with spinal cord injury for 40 years. I have a member in my family who has a spinal cord injury, which is kind of ironic, I think, because it was not there when I started in this profession, but is now. So do I think that it's possible for a cure? Yes, 100%. I think in my mind, in my personal opinion, I think there is a cure that's coming. Now, we make huge dramatic strides in this, but like any type of research, there are starts and stops. There's something that is discovered that just seems like it is the panacea, and then we get working on something else, and then we get slowed down, and then we do more work, and then another door opens. Right now, I think in 40 years, this is the biggest explosion in treatment for spinal cord injury than there has been in the previous years. So there's been things that's happened, and I think that this cure is probably going to come in a variety of ways. I would hope that someday there would be some kind of immediate treatment if somebody had a spinal cord injury, or if somebody had a disease that was causing a spinal cord injury. I would hope that someday there would be just a pill or something, a surgery, something that would just make it all go away. That would be lovely. I don't see that right now, and probably because I'm, just a small-minded person. Maybe other people do see that, but I think that the cure is going to come in a variety of ways. I think it's going to come using different therapy modalities. So there's been huge strides made in functional electrical stimulation, just the whole idea of supplying movement to the lower part of the body where it's below the level of spinal cord injury. Huge, tremendous strides in that area. We have seen through the experiments with Christopher Reeve himself, where he was given every single kind of movement therapy possible at the maximum level. Just here, let's throw the whole kitchen sink at him and let's see what sticks. And by golly, if he didn't get a huge return of function, that's well documented. It's, there's no question about that this occurred. So we know that that's one thing. Now, we also know that that's probably not practical for people to go into therapy full-time. It's, financially draining, it's physically draining, and, we know very few people that go into activity programs or exercise programs where it just becomes their life focus. You still have to go out and have a job and make money, and you have a family. But we do know people that do this, people who are bodybuilders, people who are into this extreme exercise. They're doing these kinds of things. So, but that's going to be one piece of it. And then I think there's also probably going to be some medications, and there's certainly been some wonderful outcomes with some different medications. And then there's certainly a lot on the front of surgery. As I said about this new draining of spinal cord cysts through this surgery that was done just on rats. This is just like huge news. This is fabulous news. So if that can be done, there's also been experiments done in the past where there's been success in animals, not so much in humans, but there's been success with putting stem cells or other kind of neuroregenerative type of treatment into that cyst itself. The big problem with that, much to everyone's chagrin, was that cyst has a coating around it, and it doesn't seem like those cells grow through that coating of the cyst. So you can put cells, nerve cells in there, but they won't attach because of this coating in the cyst. So people are working on that sort of thing as well. There the big idea where people were given a combination of the functional electrical stimulation, but instead of doing that outside of the body, they did actually implanted some electrodes inside the body, inside the spinal cord, and then applied all this therapy, and people have gotten recovery. It's not at the point right now where it's recovery like they were the way they were before their spinal cord injury, but it is recovery that they're able to do so many more things than they were before. So as that all gets honed down and refined and perfected, so in my mind's eye, I see it coming. Now, when you're the person with a spinal cord injury, it can never be fast enough, and I realize that. And every day is just like another day of waiting for this to come. But if you keep your body in good health, if you manage to take care of yourself well with your spinal cord injury so that you keep your skin intact, you keep your bowel and bladder function, you keep your nerves and muscles intact, so you are taking care of yourself, you will be ready for when these things come. So I am quite confident of it. I think that I'll see it in my lifetime, and I've still got a few good years in me, so I'm hoping that I will see that in my lifetime. I'm really optimistic for the day when my job won't be necessary, and I'll think, good, that's a good thing. I'll be happy to retrain and do something else. That would be great. So there you'll see in the participant feedback there's information about some of those studies that I was talking about, and so for all of our readers and listeners, it's a good idea. There's a lot of places where you can find studies. The Christopher and Dana Reeve Paralysis Foundation has funded millions of dollars in research with some quite successful outcomes. So they have really been leaders in the forefront of getting information out to people and getting clinical trials and research trials going, and really have increased the body of knowledge about what's going on. So that's really important. So let's see. Here's a person that's writing in that has been using an intermittent catheter for 5 years. Can I safely use an indwelling catheter for weekend trips and such? Well, the flat-out answer of this is a lot of people do that. You will really want to check with your personal health care provider to make sure that that's okay for you to use. When people use intermittent or indwelling catheters, they're at a much higher risk for urinary tract infections. And so you'll want to, check to make sure that that's okay for you in that regard. You want to increase your fluids while you're using that indwelling catheter. Women have a lot more difficulty maintaining intermittent catheterization because of anatomical differences. The male anatomy, it's clearly, you can see where you're going. It's clearly available to you. It's functionally much easier for a male to catheterize. For women, the urethra is more hidden. It's a little bit harder to find. It's enclosed in the meatus, so cleaning is a little more difficult. So intermittent catheterization, although clearly possible for women, it's a little bit more of a challenge. Males, if you catheterize sitting up or laying down, you can see where you're going. The catheter goes in. Women, when they're laying down in bed and they look to see where the opening to their bladder is, the meatus, it will be at one angle, but when you're sitting up at on the toilet, it's at a slightly different angle, which makes it even a little bit more cumbersome. Women can't see the opening without using a mirror. It's not as clear as it is on the male human body. So it's a little bit more difficult. So it's not usually, if you're using intermittent, that is really regarded as the best and the safest, because once you have that indwelling catheter in there, you have a clear opening for bacteria to just crawl right up there. So it's a lot riskier. So talk to your primary care physician about this, the person who's guiding you in either your urologist or your spinal cord injury specialist, and ask them what their opinion is about that. But there are women who do that because of complications, but they'll take it out. When you have the indwelling catheter in there, the urinary sphincter gets dilated, so it becomes slower to close back up. So sometimes if you use an indwelling catheter, even just for a couple of days, sometimes the urethra will dilate and open, making you incontinent when you take the catheter out. And so that meatus sometimes doesn't close up tightly enough. So there are a lot of reasons not to do that. But as I do say, I do know people that do that. So, talk to your physician about that to see what would be best for you. It's not really something that we recommend, but, life takes different twists and turns, and sometimes you have to do things a little differently. So here's another question about, have you ever talked to other patients? Are you familiar with injecting Botox around the outer lining of the bladder? Yes. Following the surgery, I no longer needed to use a leg bag. The only time I kick off is when I cath throughout the day. The surgery lasts 8 to 10 months, must be injected yearly. Okay, this person really liked that. There is a procedure where Botox is injected into the bladder itself. So they put a tube up into the urethra, and they have an implement that has a needle on the end of it, and they inject Botox into the bladder, the inside of the bladder wall. This is not an uncommon procedure, and it's done for people who have a spastic bladder. So their bladder is, your bladder is constantly working on contractions. The bladder is kind of a neat thing. So as it fills, the bladder is always contracting, just very slightly, always, always, always. That's its job. And so as more and more urine fills in that bladder, the contractions get stronger and stronger and stronger. And if you do not have a spinal cord injury, when those contractions get really strong is when your brain says, you have to go to the bathroom. And that's when you notice, oh, my bladder's full. Oh, I better go find a place to go to the bathroom. And if you decide not to go for that moment, you can tighten your urethra and hold it for a little bit until you can get to a place where you can aesthetically empty your bladder. So what happens after a spinal cord injury, sometimes that contracting of the bladder gets out of sync. So the bladder's contracting, but your urethra is also contracting, so that you have this dyssynergia, it's called. So everything is contracting, so you can't squeeze the urine out because the urethra is too tight. And sometimes that contracting just gets so strong, it doesn't ever slow down. And so what happens, even if you have a weak urethra, then you'll be incontinent of urine. So depending on what kind of condition you have within your bladder, you need to have urodynamic testing. Then if you have this dyssynergia, or if you have really strong bladder contractions. Now, there's an old nurse's tale, the way of telling things. What you see on the outside is usually what's going on the inside. So if somebody has a lot of spasms in their legs, usually that means they'll have a spastic bladder and a spastic bowel. And so you can kind of tell that these things, by looking at the outside, you can see what's going on in the inside. It doesn't mean that it's always true. You can have no spasms in your leg and still have a spastic bladder because it's different nerves coming out of the end of the spinal cord. But it's a general rule to follow. So what happens is they'll inject this Botox into the bladder to calm that contracting, so you don't become incontinent, you don't have this urge, you don't have that trigger for autonomic dysreflexia. We've come full circle. So Usually the Botox only lasts 6 to 8 months. This person's going to go 8 to 10 months, so maybe they put in more Botox. It's always kind of a guess how much Botox. It's an educated guess, but it's always kind of a guess how much Botox. Now, people who do these all the time, they pretty much got it figured out. But there's no like hard and fast rule like this is the amount you should have. So they'll try with a real low amount, and sometimes they might have to put in just a little bit more. But eventually they'll know just about how much your body needs, so it becomes routine. But it has to be redone, but it can be very helpful if you have one of these really spastic bladders to help calm it down. The other thing is, if the problem is with the urethra, they can also put some Botox just in the urethra and calm that down a little bit. Botox can be used as injection through the skin to the muscles if you have leg spasms, or if you're having problems with tightening of your muscles, any kind of, if you're starting to develop a contracture because the spasm is just constant, and so the muscle won't relax. So it can help with that. Some people have Botox injected into the back muscle of their head, and it seems to resolve migraine headaches. So Botox is being used for a lot of things. It's not authorized for everything, but these are some of the treatments that it's being used for, especially in spinal cord injury. So we have a person that is writing in that they had a syringomyelia and they had surgery for it, and they were worse after surgery. So it's really, you really want to think long and hard before you have the surgery. Nobody goes in with the intention that something's going to go wrong in any surgery, but sometimes this is a really delicate surgery. You really want to get a couple of opinions about it. You really want to talk to your family. I know a lot, and really think long and hard about these kind of really delicate kind of surgeries. You really want to be open-minded about it, because people who go into surgery, who are having the surgery done on them, always think that, I'm having surgery. When I come out, I'll be better. With any surgery, no matter what kind of surgery it is, if you're having Botox injected into your bladder, if you're having a contraction release, if you're having a pressure sore, if you need to have an intervention there, if you have your gallbladder out, if you have your appendix out, any kind of surgery has risk and complications. Things happen in surgery that can be extremely disastrous, even in little minor surgeries. It's not that anybody intends to do anything wrong, but everybody's body, like I said, is just a tiny little bit different. And so sometimes things just happen because your anatomy is just a little bit off from somebody else's anatomy, or from the general anatomy or the textbook anatomy. So thinking about surgery is something that you really want to think about no matter what kind of surgery you're having. People always go in with the idea that everything's going to be wonderful, but there is that very small, very, very small percent of people who do have trouble with the surgery. So since we've come full circle, I think that we will end it there. I know there's a lot more questions that are coming up on the messenger board here. So if I did not get to your question, be sure and call in next week, or you can write to me on the blog, and I would be happy to answer your question there as well. So with that, I hope that everybody stays well and healthy. I know we have some parts of our country that are really suffering right now with all of these weather calamities. So for our friends in Puerto Rico, we're hoping that and praying that you're all safe. In Houston and Florida, we know that you're still having issues with getting things back to the way they need to be. Friends on the West Coast with the fires, we hope that you're all safe out there. And it just seems like there's a lot of natural disasters going on lately. And so Be sure and ask for help. Be sure and make yourself known. That you might need extra assistance or you might need extra equipment. There are places that you can call and get links to organizations. You can call the Christopher and Dana Reeve Paralysis Foundation and find out how you can get the equipment that you need if your equipment has been lost in some of these natural disasters. So there are people that are out there and willing to help. It's hard to get a hold of them if you have no telephone and no ways of communication, but be sure and let your needs be known because there are people who are wanting to help you. So with that, I will sign off for the day, and I hope that everybody has a great week and a great month. And with that, I'll turn it back to Tony.
Thank you for joining us today. This presentation was recorded and will be archived by the end of the week. Have a good day.